Understanding the surgical options for obesity is the most important part of this presentation. Please pay attention to the different kinds of surgery and try to determine which procedure might be optimal for which patient. The National Institutes of Health set out guidelines in 1991 that outlined when surgery might be indicated. In patients with a body mass index over 40, that represents a group of patients that is very unlikely to benefit from medication and has a high probability of benefiting from surgery. Likewise, in patients with a body mass index over 35, when there are other medical conditions that exist, that could represent another group of patients that would be a candidate for considering surgery. In 2010, the NIH also approved weight loss surgery in patients who have a BMI between 30 and 35. That's approximately 40 to 70 pounds overweight. In that circumstance, when they have additional medical conditions like diabetes, hypertension, gastric reflux, and others, that might be a circumstance where surgery could dramatically improve survival and reduce those comorbid conditions. There are 3 basic operations available in America today for weight loss surgery: the lap band, lap sleeve, and lap bypass. The next few slides will cover in great detail each of these operations. Then we will also cover information about which operation might be optimal for which patients. This presentation will not cover outdated surgeries or rarely utilized surgeries as listed below. In order to better understand the types of surgery, it's helpful to understand the normal anatomy. If you can follow the flow of food down the esophagus into the large reservoir, the stomach, and then it moves around about 12 or 13 feet of small intestines and eventually makes its way to the colon, where there's about 6 feet of large colon, eventually ending in the rectum. The gastric banding has been widely used for approximately 10 years. It involves a plastic device wrapped around the upper stomach, and that creates a small pouch. It's attached to a tubing that it goes to a port that we fill with fluid. Now the fluid fills the band and that tightens that zone. So when you eat, the food goes down to that pouch and it feels tighter. The advantages of the band may be that it's technically less complex to put in and it is adjustable, allowing us to tighten it. Some of the limitations might include the areas of complication like a potential slip or an erosion where part of the band erodes into the stomach. There are sometimes problems related to the port under the skin. And then lastly, some people will develop reflux. These are all found on the presentation related to complications. When you have a band, it's very important that you must eat solid food and not slider food. What that means is we want you eating dense foods like chicken and bread and fish and vegetables. We prefer that you not eat a lot of slider foods like soup and oatmeal and cereal and yogurt. Those foods will go through unimpeded and may not give you the sense of fullness. Lastly, it's important not to sip with meals. If you sip with meals, then it also can turn the food that you eat somewhat into a slider food. The gastric sleeve is a procedure that we've been performing for approximately 5 years. It basically takes a large holding tank, your stomach, and turns it into a tube or a sleeve. The volume of that sleeve is now only about 3 ounces. As you eat, that stomach gets full and it sends signals that your stomach is full. The outer part of the stomach that is excised or thrown away, it contains hormones that actually cause hunger. And so those hunger hormones are decreased. Some of the advantages that some people consider are the fact that there is no foreign body and that there's no rerouting. Some of the limitations is that we do see weight loss that is about 70% of the excess body weight. There's somewhat limited data now with 5-year experience. And finally, there are the occasional patients with gastric reflux problems. That's an aspect of this surgery that we're studying carefully by measuring the pressures in the esophagus and ideally fixing those at the time of the surgery.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
The gastric bypass is the final operation that we would discuss. You can see from the photograph that it is consisting of a small pouch, and then the small bowel is hooked up to that small pouch. The lower stomach stays right where it's at. If one were to ever want to hook those back together, it is clearly reversible. Some of the advantages of the gastric bypass might include that the weight loss is approximately 80% of your excess body weight. Some people argue that the intolerance of sugars is somewhat of an advantage. When you eat sugars, like liquid ice cream or Kool-Aid or soda pop that contain sugar, it goes down into that small bowel and it creates a sugar elevation, but then about an hour later, a sugar drop. And that causes hypoglycemia, making you feel jittery. In that sense, it encourages you to avoid sugars. Some of the other limitations might include the small risk of ulcers in the small bowel and the temporary risk of stricture where the pouch is connected. Other complications will be dealt with in the separate slides related to complications. This is a video animation of a gastric bypass. You can see the first step is just dividing the upper stomach. Then we bring a loop of small bowel right up to the small pouch. Fluid goes down into the pouch and that signals a full stomach. And then it passes down the intestines. And at this point, the rest of the juices join with it, and virtually all your nutrients are then absorbed.